Gunter. I am doing my final lecture for EMS instructor methodology. We have to do acid-base balance lecture today. I really appreciate you letting me come here and do my spiel to you guys. If you guys have any questions throughout this presentation, please feel free to ask. Just raise your hands, it's super informal. Grab my little clicker. So we have some objectives for this lecture, okay? We're going to talk about what is pH. We're going to talk about what our, we're going to learn about the acid and the base. We're going to discuss how pH is controlled in the body. We're going to study and discuss the body's buffer systems. We're going to do in-depth descriptions of respiratory acidosis and respiratory alkalosis, and in-depth descriptions of metabolic acidosis and metabolic alkalosis. I'm also going to do a short just talk with you guys about the different tools that are available to us in EMS that can help us monitor the body's pH or tell us if a patient is in respiratory alkalosis or acidosis, and the same for metabolic. Treatments then for acid and base imbalances that we may come across in the field. This actually will help you guys in your assessments, since you're doing your primary and secondaries and learn how to do those. The bare minimum information that you guys find for us as first responders will really help us to kind of figure out which rabbit hole to go down to help treat our patients and maybe find out exactly what's wrong with them. Through the years of running calls and having good relationships with ER doctors and ER nurses and clinical coordinators at the hospital and nurse educators that are able to go back in and look up the outcomes of my patients, I've been able to kind of further learn about what assessment tools I use and how I do my differential diagnoses for my patients. I'll talk about a really bad call I actually had recently that I had to actually think pretty hard on, try to give the ER charge nurse a heads up on the call that I was bringing in. So what is pH? pH stands for potential hydrogen. pH is easily equated to the number of hydrogen ions in the body. Okay, the body makes hydrogen ions, and the buffer system, which we'll talk about, kind of coagulates them and figures out where they go. The pH scale runs from 0 to 14, right? So you've got, I'll do it over here so you guys can see. You've got 0 on a scale all the way to 14. Right in the middle is 7, right? Our body's stable pH is between 7.35 and 7.45. It's a very, when you look at this scale, it's a very, very micro number before our bodies can either go one way or the other, and very quickly, okay? The pH of blood is 7.4. So if you go by this, it is just slightly basic. It's alkalotic, right? Acidosis, acid and base. So acidosis is on one side and alkalosis is on the other. This is acid and this is base, okay? And both can be extremely detrimental in their own rights, okay? Acid, right? Acid increases and releases hydrogen ions in water, all right? Increased acidity is expressed as a number that is less than 7 typically, okay? Acids are more of a threat than bases. There's always a constant of metabolic production of acid due to the constant production of CO2 in the body. All right? We bring oxygen in, we put it through our bodies, CO2 is expelled, right? So CO2 is kind of considered an acid, so therefore we always have acid present in our bodies. Acidic examples. So your household vinegar has an acidic value of 3, which is vinegar. Black coffee, which I kind of found interesting because I didn't know this, is 5. Because the joke is, public safety, EMS, first responders run off coffee, black coffee and bangs, or rains, right? So this is something to think about when you are going on call to assess a patient. Bases. Bases decrease and accepts hydrogen ions in the water. So acid gives them away, and bases take them on, right? So you've got, I'm going to tackle this board before the end of the day. Baking soda has a pH of 9. Does anybody use baking soda for any ailments in their daily lives? Ailments, they're cleaning.
Use it for goats, not bad.
How have you used it for goats?
Bloating.
With what? Bloating?
Excessive bloating.
Really?
Yeah, free choice will help out with the, because when they bloat, they form the bubble in there.
That acid, yeah, like the buildup of gas, right?
It'll help break it down so it'll pass through it.
Because we do that for cows too, but I didn't think about goats, but that makes complete sense. So ammonia is up here. My grandma used to swear she had this big tile floor in her kitchen, and she would swear she would sprinkle it. Made the biggest mess. I don't know why she did it, but she would sprinkle it with baking soda, and then she would pour, like, spray vinegar over top of it, and she swore it cleaned the grout between the tiles, and it did. It was a big mess because it turns into that paste-like. So base is just as needed. Base is just as needed as base, but alkalosis is just as dangerous as an acid. So base is just as needed as an acid. That's what it should have said. But alkalosis is just as dangerous as acidosis. Okay? So your body does incredible things without us even realizing that it does it. Okay? I just tried to blast my laser, I'm so sorry. Alright, so acid-base balance. 3 ways the body balances acid and bases. Okay? The buffer system, the respiratory system, and the renal system. Have you guys talked about systems yet? Body systems? Okay, good. So the buffer system is the fastest. This is made up of your plasma and your blood. Okay? It's your body's first line of defense and also the fastest. It uptakes additional hydrogen ions and releases them when a deficiency is noted. So like, we'll use me for example. I've joined a gym for years. I am not the poster child for that gym because I don't go all the time. But when I do, my body probably wonders what just happened. Because I decide that the shred app sounds like a good idea. I do 45 minutes of squats. And my body, the lactic acid that just built up in my body, or anybody's body, is insane. Same thing with you guys when you guys go into a fire, right? Your adrenaline, right? You get that norepi release, blood shunts to your core, your heart rate goes up, all that stuff. You're using your muscles. Even if you go and work out, you're still using muscles that you don't typically use in an everyday fashion, and your lactic acid builds up. That's why when we do firefighter rehab, we bring you guys in after your bottle, we sit you down, we cool you off, we give you water, and we'll give you oxygen if you need it, but we take your vitals. We're concerned about your heart rate and all that stuff. Studies have been shown they're building these new firehouses, right, where the lights kind of go on when your tones drop, and then they kind of get brighter, either as you walk out of your bedroom and down the hall and into the bay, or they get brighter in your bedroom slowly, and then they get or they're dim and then they get gradually brighter. The new 82 house up on the hill, they've kind of done a similar system like that. Because your heart rate speeds up like that, there's automatically that shift in your body, and they don't, it's not good for you to have that continually happen for decades while you're in the fire service or in EMS. And they have all this scientific information and all these studies that are proving of trying to figure out ways to jar us awake and get our attention but to also do it in a way that's not detrimental to our overall health, okay? Your respiratory system is a little slower. It's when CO2 is detected at a higher level. The respiratory system increases the rate and depth of breathing to regulate a body's CO2 retention, okay? Your renal system is your slowest, all right? If you get so sick that you are reliant, that you have done something to your renal system may end up actually getting worse before it gets better, or just may get worse, and then that will be how you perish, because once your renal system can't keep up, your organs will eventually shut down. The kidneys regulate the body's pH by excreting the hydrogen ions and bicarbonate ions. Okay guys, so look at this. I know, right? Sounds like chemistry class, but seriously, this is what it is. Hydrogen ions look like this. Okay? Bicarbonate ions look like this. Right? So, when you actually add these together like a mathematical equation, two there. It's this. H2, which is water, which then comes out, is urine in your kidneys. Right? This gets filtered back. So, not super difficult. It just sounds intimidating. That was one of my hardest problems when I was in paramedic school. All the textbooks and everything, they like to make things with really big words and ions and cations and potassium and this and that, and I couldn't keep up because I don't think like that. All right, so respiratory acidosis. Okay, so we've got causes down here, which the next slide is also causes. So if you can't see these, we'll go to the next one. You'll usually have hypoventilation, hypoxia, which will lead to hypoxia. You slow down so much, you've been threatened to stop. You may have rapid shallow respirations. Your blood pressure may tank. Your skin and mucosa will be pale to cyanotic. So you're first looking at nail beds, that kind of thing, hands, feet, lips. When the lips become pale because they're so close to your core, that is when you really should start to worry, and hopefully you're going about an intervention to right this wrong. They may complain of a headache. They'll have hyperkalemia, and their dysrhythmia is because they have an increase of potassium in their blood. Drowsiness, dizziness, disorientation, muscle weakness, hyperreflexia. So, what differential diagnosis? If we get called out for a 31 Charlie, which is an unresponsive, so middle of the road, right, Charlie call for unresponsive, because maybe Momo's drowsy, dizzy, and just disoriented, right? What are some possible medical conditions that she could have that would cause her, if her pH is dropping and her CO2 is rising, because it's being retained in the lungs, the CO2 is stuck in her chest, in her lungs. Do you guys have any idea what they could be? You're correct. Yes, it can. And yes, hyperventilating. So they say hypoventilation, and then they come down here and it's rapid, slow respiration. So rapid is actually hyperventilation. But COPD can go both ways. It depends how serious on the scale. Did the COPDer is a bad breather in general? Did they just start? Or are we nearing the end of them not being able to compensate for the CO2 in their blood any longer? Okay. So I don't know if you guys can see this because these pictures are they should really be on two separate slides. So COPD is a chronic airflow limitation. Emphysema and chronic bronchitis, and your COPD, these I call when they have respiratory trifecta, is when they have emphysema, COPD, and then CHF, which is congestive heart failure. So not only are their lungs shut, but their heart's having a hard time keeping up too. These are the kind of people that you gotta be on the lookout. The COPDers, these bad breathers like this, are the ones that probably smoked in their offices while they worked when they were our age. Smoking was allowed in hospitals, doctors' offices, restaurants, and their place of work, right? So they're very easily fatigued, okay? They can't stay without a respiratory infection, okay? A lot of times because they have a hard time, if they get anything in their lungs, like mucus or the starts of pneumonia, they have a hard time bringing it up. Use of accessory muscles to breathe, that's what we were talking about earlier when you lift up their shirt just a little bit. Sometimes you can see it through their shirt, where they're using their muscles, their abdominal muscles. They have those retractions. Wheezing, they do that pursed lip breathing because they're just trying to draw in as much air as they can. They'll have a chronic cough. It's usually a dry, non-productive cough if it's a chronic cough. They have that barrel chest that we talked about because their upper body just starts to atrophy from the battle with their body up for the whole time. Dyspnea, the difficulty breathing, prolonged expiratory time. Bronchitis usually comes with increased sputum. And digital clubbing. So we didn't talk about this earlier when we talked about COPD, so we'll talk about it now. Patients that have clubbing in their fingers, their fingers will look like Fred Flintstone's cartoon hands. I mean, they will be very blunt on the end. They will almost look like maybe had been like an amputation there, but there's not. It's just the way their fingers end up looking. And I could have done you one solid and looked up the physiology of why that is like that. I don't know. I do remember my uncle. My uncle had terrible emphysema. And I remember him, they have that prolonged expiratory phase, so they breathe in, when they blow out, because what they're trying to do is blow out that excess CO2. That they bring in plenty of oxygen, but they cannot expel it because of that barrel chesting and that atrophy. They can't push it out. So what happens is when bad breathers come to us or we go to them, they're typically starting to decompensate. They're no longer compensating. COPDers, emphysema, chronic bronchitis, they are used to living with some kind of respiratory discomfort. But usually when they call us is when it gets so bad that we have to treat them with quite a few different drugs. They're typically thin in appearance, so they usually carry around oxygen or the oxygen is not far away. One of my favorite things about people with oxygen and home health and home concentrators, has anybody seen an oxygen concentrator in somebody's home? So it's this little box that sits on the ground, it's got wheels, it has this little reservoir that has a little bit of water in it that bubbles when it's turned on. It's got a dial that looks like an oxygen tree in your ambulance. And it has it's usually hooked to like an M cylinder, which is one of the really bigger oxygen cylinders. And then the patient has this extremely long tube that they could run half a football field with. And it's usually on 2 liters, okay? But by the time you push 2 liters through 25 feet of hosing, they're probably getting a half a liter in general. So in EMS, we find ourselves a lot doing patient education, and we're like, well, I understand that you want to be able to run from room X to Y, but you're going to have to we're going to have to figure out how to get you a portable one or whatever, because if their respiratory diseases are progressing, they're going to have to bump up those liters per minute, which is going to change the prescription of their oxygen. Because the doctor, if they say you're going to be on 2 liters 24/7, they do the equation, they do the math, they figure it out, and the insurance says, okay, well your doctor wrote for 2 liters of oxygen per minute for 24 hours consistently for a month. This is how much oxygen this is going to take, and this is how much we're going to give you for the month. And it's kind of like insulin. When you're out, you're out. You can't refill without a new prescription. So before we go changing any patient's oxygen concentrators and telling them, well, just put it on 4 and sign my refusal and we'll get out of your hair. just remember that 4 is going to be used up quicker, and then that's going to put them in a bind. It may not put them in a bind tomorrow or by the end of the week, but by the end of the month, or however long that oxygen is supposed to last them for, it will cause them to have an issue. Okay. Asthma is another one of respiratory acidosis. Okay. Hypersensitivity. You got brittle asthmatics that can't walk by really strong cologne. Now, does anybody in here have asthma? Typically not, because you guys will find it really hard to breathe if you get an asthma attack and an SCBA. It's a greater occurrence in males. It usually onsets itself before age 12. There's all kind of studies out there. Sometimes dogs and allergens will not cause patients to have asthma. Sometimes they will. I really think it's more hereditary, but what do I know? If they have asthma and they have an asthmatic attack, they will have the retractions, they'll have a cough, they have increase of mucus, they have shortness of breath, they'll have the expiratory wheezes, and again, they have the CO2 retention. They have the prolonged expiration too, because they're trying to blow off that additional CO2. Status asthmaticus is very terrifying. A mom can have 2 kids that are both in their preteens that have had asthma since they were 3. She's been thrown everything from the croup to the flu to her kids having just random asthma attacks running around on a football field. But status asthmaticus can happen at any time. It can happen when the patient's 3, it can happen when the patient's 12. It could have never happened for 8 years and then all of a sudden hit them. It's terrible, it's a very hard thing to break, and that's usually when we end up, because they've been trying to treat for hours with their own at-home breathing treatments, and it's just not getting any better. I had a woman that was in status asthmaticus. We rolled up into the doctor's office. I knocked on the door, and the woman was sitting up. She was tripoding. They had her on 2 liters of oxygen. She had audible wheezes. I could hear through the door of the exam room. And I walk in, and a nurse is standing in the room like this. And this woman is working. I mean, she is working for everything I got. I was with a senior P that day, and I turned to him, and he already had it going. We threw a nebulizer on her. We threw her on the stretcher. And she said, "I'm so tired." If somebody has asthma, and they've been breathing like that since, because her daughter told me it was the night before that it started, her mother did not want her daughter to call 911. If somebody in status asthmaticus tells you that they're tired, you better be ready, because they may respiratory arrest. All right, they're losing that drive. They're losing all drive to breathe. We get her to the hospital. We had to wait a bed because of ER bed shortages. We waited with her for about 25 minutes, and she got to the point where she was putting her hands over the neb mask treatment to try to keep all the medication in and just trying to breathe it in as best she could. I mean, I hit her with everything I could. We finally got her in the room, and I'm waiting for a nurse to come in to take reports so I can leave. And she throws her head back on the stretcher, and she says, "Honey, I'm tired." And so I run out the room. I said, "Hold that thought." I run out the room. I grab the doc. I said, "Do you want to intubate her, or do you want me to?" And he was transcribing. He turned around. He said, "What?" I said, "I've got a status asthmaticus in here that sat in your hallway for 45 minutes. I said, "This is the 3rd time she's told me she's tired." I said, "Do you want to intubate her, or do you want me to?" And he went running in the room with me, and he started ordering all kinds of stuff. That poor respiratory therapists were really busy that day. But luckily, she didn't arrest. But it is a terrifying sensation to know that it's impending for that patient. So just be aware if somebody tells you that they're getting tired and they're having difficulty breathing. It doesn't have to be status asthmaticus. It could be COPD. It could be emphysema. Okay? My aunt watched my uncle pass away right in front of her. He literally got so bad that he just respiratory arrested. And she didn't even realize what was happening because he had just come out of a really hot shower in a hotel in a city that they weren't in. They were just traveling through, and he straight up respiratory arrested right in front of her. So then you've got respiratory alkalosis. Hyperreflexes and muscle cramping. They can have seizures. Their pH is going up. okay? Their CO2 is coming down. It's the loss of the CO2 from the lungs. They're blowing it off faster than they can make it, okay? Their expiratory is probably just a hair longer than their inspiratory and is throwing everything off, right? You got your hyperventilation, so your increase of rate and death. You got tachycardia, because when you start breathing fast like that, your heart rate is going to try to keep up to compensate for everything that's going on in your body. You may have a normal blood pressure, but you also may become hypotensive if you keep it up, okay? Hypokalemia, because the lack of potassium, because it's going to throw everything off in your body. The numbness and tingling in extremities. Lots of people that hyperventilate, they may be very upset from a traumatic experience or whatever. If they get to the point where they're hyperventilating, they may feel my hands feel tingly. We go on a lot of like a 31 alpha, which is like a unresponsive, patient's just not responding appropriately. And what we're actually, once we get there and we figure it out by talking to people and calming the patient down, is we just attended an anxiety attack, is what we did, or a panic attack. But whoever called it in didn't know how to describe what was happening, or didn't know what was happening, because it could just be somebody sitting in their car outside the bank that thought they maybe had $200 to feed their family for 4 weeks, and now they have $50. So can be all different kinds of things that can happen. Irritability. A lot of times you get patients, we end up going out to law enforcement that are sitting there with a very irritated patient. Maybe they don't want to go to jail. Maybe the weed wasn't theirs. Somebody planted it in their car. Whatever happened. And they're breathing heavy and huffing and puffing, and they're doing the same thing. Anxiety is another one. We see a lot of that. Seizures, yes. In essence, yes. A lot of times during seizures, though, people become apneic. They stop breathing for short periods of time. Causes, obviously, hyperventilation, so anxiety. They actually can have a pulmonary embolism, too. You become tachypneic, which is quick breathing or hyperventilation. You can have chest pain. If you're still conscious when you realize that you're turning purple from like the nipple line up, you probably do have a PE, and you probably won't be with us much longer unless some intervention happens very quickly. Or mechanical ventilation. So guys, when you are on the scene of a respiratory arrest or a cardiac arrest and you are ventilating a patient, right? It may be your first time, you're stuck between a medic, and you're like, yeah, we're doing this, saving lives, rocking it out, and you're ventilating, and all of a sudden I tell you, whoa man, slow down, count it out. Because I look over and you're just pumping that bag as fast as you can. And it happens to the most seasoned people. A lot of times, because it's kind of like one of those skills where people start to take in the sights around them, and the bagging just becomes kind of a normal occurrence, and so they don't really think to ensure that they have a proper seal and to bag, every 6 seconds or so. We used to have these intrinsic devices on our that we would stick on the bag valve mask or on the ET tube that would attach to the BVM bag. And its only job, it was this big plastic piece. It was like 3 inches high and about 2.5 inches in diameter, and literally all it did was have this little red light on it that blinked every 6 seconds. But that was just so people knew when to hit the bag. So you can throw somebody, not that they won't be in all kinds of metabolic acid and alkalosis and everything if they code, but you can also do it on a patient that is, that maybe just has a closed head injury or something like that. Hyperventilating anybody with increased cranial pressure is a no-no anymore. It used to be a thing, like, oh, let's hyperventilate them, let's blow off all the CO2, they've learned now that it actually increases their intracranial pressure, so they have actually gone away from that. They want you to bag appropriately to keep their end tidal within a normal range, which is 35 to 45, and then they want you to keep their blood pressure right at about 90 systolic. And that's what they've found to be the nice happy medium for ICP patients. Which you guys work in this long enough, you will see plenty of wrecks with plenty of people with closed head injuries, tragically. So hyperventilation, high altitude, that's something to think about, high altitude sickness, or for people that go and wander off to Colorado that come from sea level over in Brunswick County. They may have trouble adjusting. Pregnancy is another one, because come about week 32, you got a minion right about here, and God forbid you eat something while you got a minion here, because you can't breathe real well. Sepsis will definitely do that. Hyperventilation, guys, comes with compensation, starts to come with decompensation. Sepsis is a very, very, very dangerous infection. There are some EMS agencies around the country that are doing alerting to sepsis protocol. They have the machines that start running kind of like labs. They have, like we call a code stroke, so it alerts like a neurology team. They have them where they call code sepsis, and it alerts an entire team of doctors that will show up at the ER awaiting your arrival to immediately start treating the patient. Anxiety, we covered that. Pulmonary emboli, hypoxia, so lack of oxygen, right? Fever. Guys, when you're sick, your body kind of goes into overdrive. You and I don't necessarily notice it when we're sick because we're trying to just cuddle up on the couch and throw the blanket off and bring the blanket back on, and throw the blanket off and bring it back on. But your respiratory drive actually does, you do become slightly tachypnic. Overdose. Salicylate is aspirin. Okay? Doesn't sound like that, like a very big deal to us, and it's not. We wouldn't know it because they won't find it out until labs come back from the hospital. But something to think about if you go, we have a lot of patients that live here in this service area that they have onset dementia, right, or Alzheimer's, but they have begged their kids to let them stay at home, all right? And we do have some very good families around here that do whatever they can to let their parents stay at home as long as they can. But they can't be with them 24/7, and sometimes they can't either find the help or afford the help to be with them 24/7. So if you walk in and Mama is sitting there and she has got a bottle of aspirin and is close to empty, and you know that Mama probably lives there by herself, but Mama doesn't go a lot of places, or she definitely doesn't drive anymore, if their daughter or brother or son or whoever shows up and says, "When the last time did you buy that aspirin?" And if it's like, "Well, I just bought it last week." Well, it's empty. So again, being alert to your scene around your patient as well as your patient. Neurological disorders. So do me a favor, I hope all your hands are raised. Who here has seen Waterboy? Okay. So we all know that the medulla oblongata controls breathing, right? So affecting medullary respiratory center. All that means is that if something's wrong with your noggin that is screwing with your medulla oblongata, you may not have the proper respiratory drive that you're supposed to. So, 5 points extra today. All right, guys. These are the electrolytes that affect acid and base balance. Now, they're not all of them. Okay, these are just some of them. But I want to make sure that we kind of talk just a little bit about it, so that you guys kind of sort of get the gist, the general gist of what we're discussing. Sodium, calcium, potassium, magnesium, and glucose, obviously, all are parts of your heart. Okay, you have a sodium, potassium pump in your heart. That makes the world go round. Calcium also has an effect. We give a medication for a rapid irregular heartbeat called Partizan, which is a calcium channel blocker. So just think of it like, in the grand scheme of things, when you if you're looking under a microscope, right, you've got like these little dishes in your physiologicalness of your body, and your calcium fits right here, right? Well, if your heart rate is irregular, what it's going to do is that medicine will block that channel, so the calcium can't come down in there, and it will slow the heart down. It's like This service that I work for, if it's anything less than 70, we treat it. We treat it with oral glucose, okay? If it's 69, sometimes I'll ride that wave into the hospital and hopefully they can get them some peanut butter or something, or they'll just give them more glucose. You got your magnesium that runs 1.5 to 2.5 milliequivalents per liter, potassium 3.5 to 5 milliequivalents per liter, and sodium is 136 to 147 milliequivalents per liter. Guys, I don't see these numbers either. Just know hyperkalemia, calcemia, hypermagnesium, and all those mean that their values were high. Hypo is low, right? Hyper and hypo, it's just like a blood pressure. We're doing good. Metabolic acidosis, okay? Headache, decreased blood pressure, hyperkalemia, you might have muscle twitching or cramping. Warm, flushed skin because of vasodilation, so like your peripheral, like your capillaries and everything, the patient will look terrible, but their cheeks will be red, rosy red. Nausea, vomiting, diarrhea, changes in LOC, confusion, increase in drowsiness. These Kussmaul respirations, like they're trying to blow off steam, almost, I call it like blow off steam. So this is what you'll see with diabetic ketoacidosis patients. There's a picture on Facebook. It's back in the day when they found out about insulin and figured it out, how to treat. There was a room full of pediatrics all in diabetic coma because their sugars were through the roof. And that was when they started going through and trying to give them all insulin. And the room went from doom and gloom because the parents were all getting ready to say goodbye to their children because they were all going to perish in a day, in a week, in a month. And they went through the whole room and proceeded to administer this insulin that they had just figured out how to obtain. And the whole room all the kids started to wake up in the room. That was one of the ways that they realized that insulin worked for diabetic ketoacidosis. If somebody has severe diarrhea and has had it for a couple weeks, this is how they could present. Renal failure will present like this, and shock will present like this. The ability of the kidney to excrete acid and conserve base will decrease greatly. Their pH will drop and their bicarbonate will drop. Guys, when you go to a patient that they may be a diabetic, they may not be. The last time I went to a diabetic, I walked in, it was two brothers that lived together, they were in their 60s. Life had not been really kind to either one of them. But I walked in the house and we got called out there for altered mental status. And I walked in and I was like, really? Y'all called us out here because you've been drinking? And the brother was like, well, the patient that we were there for, he was altered, definitely. And I'm saying this to them as my partner is obtaining his glucose. And the brother's like, he's ripped apart his room, he keeps trashing the house, he just keeps looking for things he can't stand. And I said, well, y'all are drinking. I said, it smells like a liquor still in here. He's like, ma'am, I got a beer open there, but he said, that's the first one I've had today. He's like, I do drink, but this is honestly the first beer I've had today. Because it was like 4 o'clock in the afternoon. And about the time I put 2 and 2 together, it was like fireworks went off. My partner was like, oh, well, because your glucometer reads to 600. Ours do on the truck. After that, it just blinks high. He said, well, his sugar's so high, it's just high. It's telling me hello. And so I was like, okay. He's a diabetic. He was in diabetic ketoacidosis. So here we are. But with that, he had a UTI. He had acute renal failure because the UTI got so bad. Then diabetic ketoacidosis happened. So these people, they won't look so bad. When they blow off these ketones that they talk about, they say they have a fruity smell to them. The only time I've ever smelled them, it has smelled like acetone, like a bottle of nail polish remover, or has smelled like a liquor still. It sounds like somebody's cooking something up bad, okay? It may be sweet to you, I really just think it's the individual's perception of it. So, here we go guys, DKA causes of metabolic acidosis, severe diarrhea, the stomach flu, or IBS. Okay, you guys know irritable bowel syndrome, it's not a whole lot of fun to talk about, but a lot of the population suffers from it, believe it or not. Renal failure and shock. So this is kind of something that your body gets thrown into during shock, but it's in a a couple phases into shock, not like initial, in phase 1 of shock. Metabolic alkalosis, dizzy, increased irritability, nausea, vomiting, diarrhea, increase in anxiety and seizures, tremor, muscle cramps, tingling in fingers and toes, confusion, dysrhythmia, tachycardia from decreased potassium, and compensatory hypoventilation. Causes is an increase in bicarbonate, which is antacids, administration of sodium bicarbonate. So when you see this mainly is a lot of times we'll go out to these chest pain patients, right? They've been having pain for 3 days. Somehow the good Lord was smiling down on them and allowed them to eat Tums like candy for 3 days. All right, because they think it's indigestion. Little do they know their entire left side of their heart may be blocked because they're having a heart attack bigger than hell, but they don't realize it. But what all they've been eating continuously for 3 days straight is calcium. So you're taking an influx of a massive amount of calcium into your body, and it's going to throw off your heart. That is one of the electrolytes that controls your heart's rhythm, rate, all that good stuff, right? And then a decrease in hydrogen. So like if you're suctioning, NG tube suctioning, NG tube suctioning, prolonged vomiting, I can't remember. Hypocortisolism, so increase in cortisol. Decrease in acid or an increase in base. The pH usually goes up, so does the bicarbonate. Because calcium is a base. So obviously everything's going to go this way on the scale. Okay. Excessive diuretics. You'll see this a lot in people that maybe the doctor gave them 40 milligrams twice a day of Lasix, and they needed that for however long to pee off all the excess fluid. But then the patient, they called and said, "Hey, Mr. Smith, please only take half a pill twice a day." And the patient didn't check their voicemail, didn't care, couldn't hear the patient or couldn't hear the nurse. It doesn't understand has been taking 40 milligrams of Lasix in excess for however long their prescriptions run out, until they run out. So that may cause that. Excessive administration of sodium bicarb. One of the only times I even reach for sodium bicarb in my truck is during a code with a renal patient. So a patient that's on dialysis or known to have renal failure. pH is increased, CO2 remains the same in the body. Treatment for acidosis and alkalosis, you got capnography, lab draws, pulse ox, O2, nebulized medications such as albuterol and Atrovent, salmeterol. You've got IVs, fluid boluses, sodium bicarb, and then administration of electrolytes. Okay, so EMS and hospital, 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 EMS and hospital. The only 2 things that we really can't do are electrolytes and lab draws. Community, we can, but we don't usually carry the banana bags to administer them. Plus, if you are going to infuse somebody with that amount of electrolytes, you really need to have base lab values. What happens is when we go out to somebody that's severely dehydrated because they've been cutting trees all day in 98-degree weather, I'll go out and I'll give you a 500 milliliter bag of fluid, and I'll call the doctor and ask if I can release you, maybe to stop your hands from cramping, or to get you from feeling so bad, or maybe to try to get you to go to the bathroom. But if you're so dehydrated that I have to give you over a liter of fluid, I need you to go to the hospital. Because if you start to dilute all those electrolytes rapidly, you will throw everything out of whack. Like I said, it's a seesaw, right? It's a give and take. And unless you monitor that influx of additional fluid, of normal saline, with their lab values, you can actually throw them all out of whack and make them much sicker. That's why we usually tell people, my brother does construction, he builds houses in the area, and he has Pedialyte popsicles in his freezer, he has Pedialyte little drink mix-ins in his truck, and he usually will carry an ice down Pedialyte to work with him. Because when I was in paramedic school, I actually showed up at his house one night when he called me because I found him fully clothed lying in his bathtub with the cold water on him. Because he had gotten so dehydrated, he was cramping so bad, he didn't know what to do. And so I went and I got him, I wanted to call 911, but he wouldn't let me. So I went and got Pedialyte, Gatorade, and water, and I sat with him up for hours, just trying to get him to the point. And once he urinated the first time, then I left him alone. But you get so dehydrated, you can throw yourself into rhabdo, which is your kidneys shutting down. And usually your urine will look like iced tea at that point. So guys, this is the pulse ox that I was talking about that most of you guys carry on your trucks or in your squad bags. This one is a little bit different. There are some fire departments around here that carry these type things that also read CO2, which we like to use those on firefighter rehab because I like to know how much CO2 you guys are holding in your body or not. It's whether I'm going to let you go back in with another bottle or I'm going to tell your chief to sit out. And firefighters don't like to be told that, and I get it, but I also don't want you to go home and die of a heart attack. Okay? I love you like my own. Capnography, there's another kind that sits on an ET tube or a King tube when you drop a King in a patient for their airway. But these are the least non-invasive. These are what I usually put on like my respiratory patients or my diabetics that I think are in DKA or renal patients. If I pick somebody up from dialysis and they just don't look good, I'll put this on a dialysis patient and it'll try to tell me different numerical values that I will use to my benefit. And then these are lab draws, guys. These are the colors of the rainbow. These two big bottles, these are blood cultures. These have a very specific way that they are drawn and the tops are clean and all that jazz. This gray one right here is called the lactic. Okay, it checks for the lactic acid in the body. They do that like with patients that we find on the floor, like old people that have fallen and don't have a phone, they haven't been able to get to one, and they were found 2.5 weeks after they fell. All right, they're very interested on what their lactic is in very sick people. Well, if they ever call for a lactic, usually know that whatever you just brought in is probably as sick or sicker than what you thought. Okay, and then I wish I could sit here and tell you that I knew what all these were, all these colors of the rainbow, but I don't. But these are all the ones that you'll see. A lot of times the nurses will yell at you to grab them out of the cart for them because the doctor ordered an additional green or an additional purple. And the one on our truck kind of looks like that, but it's all on the monitor screen together. All right, so this is a case study that I got off of GEMS online. We're going to go through, I want to go through a metabolic one and a respiratory acidosis one, and then that's the ones we're going to go through today. This one is case number 1. It's a 34-year-old female with a history of diabetes. Is found unresponsive by a family member in bed after she missed work. The patient presents unconscious and tachypnic, with dried vomit on her face and bed linens. Further examination of her primary survey shows an open, clear airway, spontaneous respirations at 40 to 50 breaths per minute, and a palpable radial pulse. Her neurological exam appears to be non-focal, her eyes open to pain. She's nonverbal and withdrawals from painful stimuli. Her Glasgow Coma Scale, her GCS, is 7. Her skin is hot and dry with dry mucous membranes. Initial vital signs include a blood pressure of 132 over 78, an EKG that reads sinus tachycardia at 122 beats per minute, a respiration rate of 48 with an SpO2 oxygen saturation of 98% on room air. Blood glucose level is high on glucometer. Secondary assessment is unremarkable with no signs of trauma or injury. So out of respiratory acidosis, alkalosis, and metabolic acidosis and alkalosis. Which one do we think that woman is suffering from? Metabolic acidosis is correct. Okay. The next one we're going to do, look, you guys are learning. I love it. A 21-year-old female with a history of IV drug abuse is found unconscious by her parents in her room. Apneic and cyanotic with constricted pupils. Hypodermic syringes with heroin are found on her bedside table. Her vital signs are respirations of 4, blood pressure of 100 over 70. EKG shows sinus tachycardia on the monitor at 132 beats per minute. Her oxygen saturation is 88 on room air with a BGL of 98. She's tolerating a NPA and an oral airway with non-invasive end tidal at 98. So it means her CO2, the CO2 should be between 35 and 45, and hers is 98. There is no signs of trauma or injury. So which one do we think it is? Yes. Yes. So, good work. All right, guys. Do you guys have any questions for me?